Good morning. I'm Nima Sharifi from Cleveland Clinic, and it's a pleasure for me to kick off the Prostate Cancer Foundation Scientific Retreat by moderating this first session on prostate cancer, androgens, and COVID-19, and to introduce the speakers. Time and again, we've all seen that in addition to supporting and promoting the best science in prostate cancer, the Prostate Cancer Foundation also plays a leading role in supporting cutting-edge science that translates into the clinic for many other diseases. COVID-19 is no exception to this rule. You may recall a Prostate Cancer Foundation Global Knowledge Exchange webinar on COVID-19 and TMPRSS2 from May of this year. This first session is focused on the sex discordance of COVID-19 and how that plays into the regulation and pharmacologic targeting of the cellular receptors for SARS-CoV-2. The first speaker is Dr. Arul Chennaiyan from the University of Michigan, who will tell us about the regulation and targeting of the SARS-CoV-2 cellular receptors, TMPRSS2 and ACE2.
My presentation is entitled Targeting Transcriptional Regulation of SARS-CoV-2 Entry Factors ACE2 and TMPRSS2. Just a bit of background. So, is there a link between prostate cancer and COVID-19? ACE2 and TMPRSS2 are critical factors for SARS-CoV-2 infection. TMPRSS2 was first characterized as being highly expressed and androgen regulated in the prostate. Our interest in particular came about due to the TMPRSS2 ERG gene fusions, which are found in upwards of 50% of prostate cancers and are also androgen regulated. Camostat, a serine protease inhibitor, which actually targets TMPRSS2, has been shown to inhibit SARS-CoV-2 in preclinical models, and you'll hear about a clinical trial with subsequent speakers. Do differences in sex hormones and their control of SARS-CoV-2 receptors have a role in COVID-19? We hope to address that. And can drugs approved in prostate cancer, which block androgen signaling, have a role in treating COVID-19? And then finally, the larger hypothesis we hope to address is targeting transcription in general of TMPRSS2 and or ACE2, a potential therapy for COVID-19. So the impact of gender and sex hormones in COVID-19. There has been tremendous interest, I would say, in terms of androgen regulation of key cofactors of SARS-CoV-2, including TMPRSS2 and ACE2. But androgen, of course, has even more profound effects on the immune system that could also explain some of the disparity between males and females in terms of the impact of COVID-19. There's been considerable data now emerging that there is a disparity between males and females in terms of the impact of COVID-19 in terms of both mortality and morbidity. The ratio of this disparity is upwards of over twofold, and this holds across different regions in Europe as well as other parts of the world, as well as across different age groups. And so the hypothesis is, do sex hormones play a role in terms of dictating these disparities between how males and females respond to COVID-19? A large epidemiological study was carried out in northern Italy. They looked at over 9,000 patients infected with SARS-CoV-2. And what they found was that prostate cancer patients treated with androgen deprivation treatment generally were less likely to be positive for SARS-CoV-2 relative to prostate cancer patients that were not on androgen deprivation treatment, suggesting that hormonal treatment or androgen deprivation treatment might actually be protective against SARS-CoV-2 infection. Interestingly, a registry study by our chair, Nima Sharifi, as well as Eric Klein and others at Cleveland Clinic, does not necessarily support these findings. Another study out of Madrid, Spain, suggested that androgenetic alopecia, colloquially referred to as male pattern baldness, has an increased association in individuals hospitalized for COVID-19. And they actually carried out a prospective study and found, although this was a relatively limited study of about 77 men treated with anti-androgens for androgenetic alopecia, they found that these men were protected against COVID-19 relative to those men that were not on an anti-androgen treatment. So to look at this in a bit more detail in terms of the expression of these key cofactors in healthy lung tissue, we took advantage of published single-cell RNA sequencing data sets. And when we looked across data sets, we found expression of ACE2, TMPRSS2, and AR in many of the key epithelial subtypes in the healthy lung, and in particular, alveolar type 2 epithelial cells across the board expressed these three genes. To extend these studies in murine models, we took advantage of, again, single-cell sequencing data from mouse lung studies. And we found that in most cases, epithelial cells were not well represented in those single-cell sequencing studies of the mouse lung. So we then ended up carrying out single nuclear RNA sequencing of healthy mouse lungs, and we were able to markedly enrich for epithelial cell types, signified by the blue colors in the left graph. When we looked at both published single-cell RNA sequencing data as well as our single nuclear RNA sequencing data set of mouse lung, we again saw expression of ACE2, TMPRSS2, and AR in the key epithelial cell types of the lung, including alveolar type 2 cells. So the next question was whether in the mouse lung, AR plays a role in regulating ACE2, TMPRSS2, and AR expression. And so what we did in this case was we took advantage of both published data sets that looked at castration and looked at both prostate as well as lung by single-cell sequencing-based approaches. On the left, we have a data set from Charles Sawyer's lab focused on the mouse prostate. And you can see that upon castration, ACE2, TMPRSS2, and AR expression are markedly decreased. Likewise, in our single nuclear RNA sequencing data set of the mouse lung, we saw again, upon castration, where you again decrease AR signaling, we saw decreased levels of ACE2, TMPRSS2, and AR in the mouse lung. To look at moving on from single cell sequencing analyses, we moved on into in situ analyses of these tissues. And here you can see basically AR immunohistochemistry for AR protein in mouse lungs, as well as in situ hybridization for both TMPRSS2 and ACE2, looking at both intact male lungs as well as castrated male lungs from mice. And what you can see here is summarized in these histograms. You can see that for AR expression, we see marked decrease in AR expression upon castration of these mice. When we added back testosterone, AR levels were again increased. Similarly, female mice had decreased levels of AR protein expression, and we could add back testosterone in females, and we can see an increase in AR expression. We saw similar trends in both TMPRSS2 expression as well as ACE2 expression shown in the subsequent graphs. We also showed that AR, TMPRSS2, and ACE2 are indeed co-expressed in lung epithelial cell types, and we saw this both in mouse, which is shown here, as well as in human cells. Now moving on to human cells, we found that AR protein expression was markedly elevated in male lungs relative to female lungs, as well as lungs from men with castration-resistant prostate cancer. And this is summarized in these graphs here. Males have high expression of AR in their lungs relative to females and relative to castrate-resistant males. However, while we saw this trend in AR protein expression, we did not see these associations with TMPRSS2 or ACE2 transcript levels when we compared males versus females in this cohort. Interestingly, when we looked at AR protein expression, we found that there was marked elevation of AR expression in males over the age of 70 relative to females over the age of 70. We did not see this difference in younger males and younger females in terms of AR protein expression. Now, to study this in a bit more detail, to at least investigate this hypothesis that anti-androgens could be used to inhibit SARS-CoV-2 infection and replication, we took advantage of a BSL-3 facility set up by Johnny Sexton at our institution that allowed us to study the live clinical isolates of SARS-CoV-2. And in this case, we're using the WA1 strain, which is essentially the first patient that was afflicted with SARS-CoV-2 in Seattle, Washington. And on the left, you see nuclei stained in blue, and in red, the nucleocapsid of the SARS-CoV-2 protein. And on the right, these cultures were incubated with remdesivir, and you can see marked inhibition of SARS-CoV-2 replication. And remdesivir, of course, is FDA approved for COVID-19 and is an RNA-dependent RNA polymerase inhibitor known to inhibit SARS-CoV-2. So taking advantage of this further, we looked at Camostat, which is a TMPRSS2 inhibitor, which I mentioned earlier, and showed that Camostat markedly inhibits SARS-CoV-2 infection, again, implicating TMPRSS2 as an important regulator of SARS-CoV-2 infection. And then we were able to test the hypothesis as to whether AR antagonists inhibit SARS-CoV-2 infection. And in this case, SARS-CoV-2 infection, the nucleocapsid staining is represented by the magenta color. And you can see that various FDA-approved AR antagonists, including apalutamide, darolutamide, and enzalutamide, inhibit SARS-CoV-2 infection in this assay, as well as did a AR degrader, ARD61B. And this data is subsequently summarized here as IC50 curves across in terms of inhibition of SARS-CoV-2 infection, as well as inhibition of the AR target genes, TMPRSS2 and ACE2 at the mRNA level. To extend this hypothesis further, we looked into the ability of BET bromodomain inhibitors in blocking this transcriptional regulation. We've previously shown that BET inhibitors could block AR signaling and that BRD4 is an important mediator of AR transcriptional signaling in general. And what we show here is that BET bromodomain inhibitors at low nanomolar levels inhibit SARS-CoV-2 infection. And this is JQ1, OTX15, as well as ZBC260, which is a BET degrader. And not only did they block SARS-CoV-2 infection, but they also blocked expression of TMPRSS2 and ACE2. We then examined the recruitment of key factors to the TMPRSS2 locus. Much of this was already known for TMPRSS2 in terms of recruitment of AR, FOXA1, and BRD4 to the cis-coded enhancer elements upstream of TMPRSS2. Likewise, by ChIP-seq analysis, we saw that AR, FOXA1, and BRD4 were recruited to the cis-encoded enhancer elements of ACE2, and there was also chromatin accessibility as measured by ATAC-seq analysis. So this then brings us to a model of transcriptional targeting of key host factors as a treatment modality for COVID-19 in terms of basically inhibiting this AR enhanceosome, whether it be by direct AR antagonists or BET inhibitors, that not only do you block the expression of TMPRSS2 as well as the TMPRSS2X fusion in prostate cancer development, but they also likely can impact the expression of the key cofactors for SARS-CoV-2 infection, ACE2 and TMPRSS2, which are certainly regulated by this enhancer, this AR enhanceosome in the context of some lung cell types. And we expect with BET inhibitors, we could even impact a broader subset of transcriptional regulators. And then finally, some take-home points. Transcriptional regulation of TMPRSS2 and ACE2 are attractive targets in the treatment of SARS-CoV-2. Single cell and nuclei analyses indicate that expression of ACE2, TMPRSS2, and AR in alveolar and bronchial epithelial cells. We showed that androgen regulates TMPRSS2, ACE2, and AR in mouse lung cell types. AR levels are markedly elevated in males versus female lungs, especially in those of older than 70 years old. AR and BRD4 are recruited to the cis-coded enhancer regions of TMPRSS2 and ACE2, regulating their expression, certainly in specific cell types in the lung and other tissues. AR and BET bromodomain antagonists inhibit SARS-CoV-2 infection in vitro, as well as clinical trials to evaluate various AR antagonists and potentially BET inhibitors in COVID-19 patients are underway. And you'll actually hear about one of those clinical trials by Matt Rettig in a subsequent talk today. With that, I'd like to acknowledge the funding agencies that supported these efforts, including the Prostate Cancer Foundation, as well as a COVID-19 supplement that we received from the National Cancer Institute, as well as a number of individuals at our institute and our collaborators, including those and especially those highlighted in red that contributed to this study. Thank you for your attention.
The second speaker is Dr. Joseph Vinetz from Yale, who will speak about a clinical trial of a TMPRSS2 inhibitor.
I want to thank Howard Sewell and Andrea Miyahara and the Prostate Cancer Foundation and the organizers for the scientific retreat for this opportunity to discuss this randomized clinical trial of Temostat versus placebo in COVID-19 outpatients. I have no disclosures other than to mention that Ono Pharmaceuticals is providing the drug at no cost for this study. The agenda today is to talk about the basics of SARS-CoV-2, the virus, and COVID-19, the disease, a little bit about current treatments, and then to go through the clinical trial design and the rationale for it. So first of all, I want to tell you and review COVID-19, the infection in humans. So this infection has many different manifestations, including absolutely nothing with affecting 40 to 50% of people can be asymptomatic. And then the rest of the people with SARS-CoV-2 infection turn into COVID-19, an infectious disease. And COVID-19, the disease, can include mild symptoms of fever, cough, fatigue. It can include more pronounced symptoms, including loss of smell and taste, severe headaches, prostration, and then it can progress over a week or two into severe pulmonary and systemic disease. What you see in this chest x-ray is an intubated patient in an ICU who has severe lung disease. It can also include myocarditis, which is inflammation of the heart, acute kidney injury with involvement of the kidney, and other manifestations, including severe pulmonary emboli and other thrombosis. So in summary, COVID-19 goes from asymptomatic to severe lung disease, and so far we can't really predict in whom that's going to happen other than we know the risk factors of a number of comorbidities. Now, the progression of COVID-19 after viral infection of the upper airways progresses to a pneumonia. And after a period of time, maybe up to a week or so, that pneumonia may progress into what we call an intercritical phase, and then either can resolve or progress into severe disease leading to hospitalization, intensive care unit, management, oxygen requirements, blood clotting, sepsis, ARDS, and death. So there's a wide variety of manifestations, and we're only beginning to understand the molecular and cellular pathogenesis of these complications. Now, how do we treat people who currently have COVID-19? Well, early in the pandemic, all we could really offer was oxygen and other general supportive measures. More recently, we've had emergency approvals for the use of remdesivir, which is an intravenous drug given in hospital to moderately severe to severely ill patients. Hydroxychloroquine and chloroquine have not proven to be useful and, in fact, may be somewhat harmful. Remdesivir is not a magic bullet. It has modest effect, and we need better antivirals. Remdesivir also has to be given in a hospital setting because there are significant adverse effects that are possible, and the medication has to be given intravenously. We do not have um, uh, uh, effective antivirals that have been shown to reduce the viral load during infection. Remdesivir has not proven to do so. And we do have adjunctive uh, management, including anti-inflammatory drugs, which can be used to treat hospitalized patients only. These are evidence-based recommendations, especially the use of corticosteroids, including low-dose dexamethasone and hydrocortisone, but only in people with moderately severe to severe disease. The effect size is about 20 to 30% reduction in mortality. And that's a solid number done in controlled clinical trials. So that's an important adjunct therapy. Now, other anti-inflammatory measures include biologics that interfere with the action of interleukin 6. And there's some mixed messages on that, but we think that that's still useful. And management in the hospital now includes anticoagulation because of the high risk of thrombosis. Again, very unusual for an infectious disease. And we also have new respiratory management in the intensive care units that have been developed over the last months. So overall, the in-hospital mortality is going down, but what we are lacking is an easily available, inexpensive, orally administered antiviral drug that kills the virus. And that's what the goal of of the current Camostat clinical trial is all about. The ideal medication for COVID-19 would be a pill to take outside the hospital. It would be used to treat sick people so they feel better, and that's important. We would like to prevent progression of disease in the outpatient setting. We would also like to have a pill that prevents transmission so that if somebody is diagnosed, then they are less likely to infect others if they have a pill that reduces the viral load. And finally, if somebody does have a high risk exposure, we would like to prevent infection to begin with as prophylaxis. So, inexpensive pill to be given for COVID-19 in the outpatient setting with a positive test or high risk exposure would be a very rational way to open up our country and our economy and our world, and would be a very important outcome. I'm not going to talk too much about vaccines. I think they're promising. They're somewhat down the road depending on who you talk to. So COVID-19 in the Camostat clinical trial really came out of prostate cancer research, where TMPRSS2 was found to be involved in prostate cancer. The TMPRSS2 gene was found to be as a fusion with ERG, which is an oncogene, which was androgen-driven expression of TMPRSS2 in the prostate cancer setting. And a lot of work, including that supported by the Prostate Cancer Foundation, has driven this part of the field forward. And in fact, TMPRSS2 expression is the culmination of a whole bunch of different ways to get to activated androgen receptors, which leads to increased expression of TMPRSS2, ACE2, and these are the ways that SARS-CoV-2 gets into cells. So let me tell you a little bit about the SARS-CoV-2 virus. We know a lot about this virus because of SARS and MERS, the Middle East Respiratory Syndrome coronaviruses. So we learned a lot about the biology, which between SARS-1 and SARS-2 are quite similar. So SARS-1 and 2, the spike protein, that triangular red piece that you see on the surface of the virus that gives the coronavirus its name for crown, the spike protein binds to ACE2 and then gets cleaved by TMPRSS2, which enables the viral membrane envelope to fuse with the target cell membrane, get inside the cell, and then go through a retrograde vesicular transport to enable viral replication. TMPRSS2 is involved in that, and a drug called Camostat was demonstrated to actually cleave. Camostat was demonstrated to inhibit the serine protease TMPRSS2, which is found on the surface of respiratory epithelial cells. And Camostat blocks TMPRSS2 as a serine protease inhibitor. Now, it turns out that Camostat is a clinically licensed drug in Japan for the treatment of pancreatitis and post-anesthesia esophagitis. And based upon previous work, Marcus Hoffman et al. In Germany demonstrated that Camostat was both hit TMPRSS2, which was both necessary and sufficient to block viral replication at a level of about 70 nanomolar of the Camostat. So that seemed to be very promising in vitro, and we decided that it would be a good idea to do a Camostat clinical trial for outpatients. Others had the same idea, so there's a number of Camostat trials in inpatients and outpatients going on. So the clinical trial is a randomized double-blind placebo-controlled design to test the hypothesis, first of all, that Camostat will have an antiviral effect on SARS-CoV-2, and that will reduce viral replication. And secondary, if you reduce viral replication, you will diminish the clinical signs and symptoms of COVID-19. The design is based on a study population of early infected outpatients that have been recently diagnosed with SARS-CoV-2 infection. Within 3 days of a positive report, we want to enroll patients into the trial. There are 2 phases. The earlier pilot phase has 114 patients to look at viral load as a primary outcome, to look at a 0.3 log 10 reduction of viral load from day 0 to day 4 in a nasopharyngeal swab in study drug versus placebo control. If we get a positive signal from this pilot phase, we'll move on to a clinical outcome phase looking at disease progression. And so we will be measuring NP swabs, and because of recent developments, we can measure viral load in saliva using the Saliva Direct assay developed at the Yale School of Public Health, and which has received an EUA from the FDA for testing for COVID-19. We'll measure daily symptom scores and clinical assessments in addition to the virological outcomes. And as I mentioned, the primary outcome in the pilot study is viral load, and secondary is the risk for referral for hospitalization and complications. In the second phase, we reverse the primary and secondary outcomes, so that if we get a positive signal, we move on to the clinical phase of the study. There are challenges in outpatient clinical trials for COVID-19. It's difficult to recruit patients. We found out that people really don't like nasopharyngeal swabs. Fortunately, we can use saliva to replace NP swabs as a specimen type for those who decline the NP swabs. We also found that in the highest at-risk communities, that is communities of color, there is a high prevalence of trust issues with carrying out clinical trials. And this is an issue that we are actively trying to address. There's also issues with study site safety. Outpatient studies with highly infectious pathogens such as COVID-19 are difficult, and they have to protect both the personnel and also the people transporting the participants in the trial to the study site. So we have found those to be real challenges. There's some future possibilities and issues. I'm confident, but we need data, that a TMPRSS2 inhibitor is going to work. There's room for optimizing drug and optimizing delivery, optimizing drug partners, and a lot of effort is now being put into developing antiviral drugs, both repurposing drugs as well as using partner drugs. There's also efforts being made for adjunctive therapy with modulation of the host response in the outpatient setting. And finally, there may one possible outcome, which is unanticipated. If we have effective antiviral treatment for COVID-19, what's going to happen to any possible induction of a protective immune response if somebody was treated with an effective antiviral? Will they still be susceptible to infection? So with that, I'm finished. I'm happy to take any questions, or if we have any discussion, that would be great. Thank you very much.
And the third speaker is Dr. Matthew Reddick from UCLA and the VA system, who will tell us about a hormonal therapy intervention trial.
Good morning. I'd like to thank the PCF for the opportunity to present the background, rationale, and design of a prospective randomized double-blind study to assess the effects of androgen deprivation therapy, ADT, on the severity of COVID-19 in hospitalized veterans. The title of the study is Hormonal Intervention for the Treatment of Veterans with COVID-19 Requiring Hospitalization, or HITCH. The PCF has been critical in making this clinical trial possible. The PCF supported the science that has established a relationship between the androgen receptor and TMPRSS2 expression. In addition, and quite importantly, the PCF has supported the VA's precision oncology program in cancer of the prostate, known as POPCAT, many of the participating sites of which are also HITCH sites. In general, the incidence of COVID-19 is similar in males and females, although some studies have observed modest differences. In contrast, there are marked differences in the severity of COVID-19 that have been consistently observed in the global pandemic. This slide demonstrates that although COVID-19 incidence is similar between the genders, the severity of the illness, as indicated by hospitalization rate, ICU admissions, death, and overall case fatality rate, are approximately twofold higher in men, irrespective of geography. Explanations for the gender differences in outcome include behavioral differences such as smoking history, presence of comorbidities such as lung and heart disease, and biological differences such as differences in sex hormones, whereby androgens may increase risk and estrogens may be protective. This slide illustrates two studies that have reported on the incidence of COVID-19 in men on ADT compared to men not on ADT. An Italian study demonstrated an approximately fourfold increase in COVID-19 incidence in men not on ADT as compared to those men on ADT. Amongst the prostate cancer patients, men on ADT had a five-fold reduction in incidence of COVID-19. The authors did not perform logistic regression analysis to correct for differences in demography, medication usage, or comorbidities, nor did they perform propensity weighting for the likelihood to be tested for COVID-19. There were too few patients on ADT to make any firm conclusions about severity of illness. A more recent study by Klein et al. Did not demonstrate a difference in COVID-19 incidence based on ADT. These authors did perform multivariate analyses to account for differences in the patients on ADT versus those not on ADT. But propensity weighting for the likelihood for being tested for COVID-19 was not performed. There were too few COVID-19 patients to address severity and outcomes of COVID-19. The VA is the largest integrated healthcare system in the United States. Approximately 9 million veterans are enrolled in the VA. 500,000 are alive with prostate cancer, of which approximately 17,000 are alive with metastatic disease. The VA has the oldest electronic medical record system in the US. Medical records for all veterans are stored in a central data warehouse and transferred to a research platform known as the VA Informatics and Computing Infrastructure, or VINCI. We undertook an analysis of COVID-19 incidence amongst veterans on ADT versus various populations not on ADT. These analyses were conducted by Dr. Kyungmin Lee of VINCI and Dr. Jennifer Lee of LEAP, the VA's Learn, Engage, Act, and Process program. Importantly, we performed logistic regression analysis to account for demographic differences, weight, age, comorbidities, medications, and marital status, amongst other factors. In addition, we performed a propensity weighting analysis to account for differences in the likelihood to be tested for COVID-19 for each of the evaluated populations. Shown here are the high-level results. Men on ADT who were tested for COVID-19 had an approximately 25% reduction in the risk of testing positive for COVID-19 compared to all veterans who were not on ADT. Men on ADT had an approximately 14% reduction in risk of testing positive compared to the subset of tested prostate cancer patients not on ADT. These findings suggest that there is a modest protective effect of ADT for testing positive for COVID-19. This modest effect is consistent with the relatively similar incidence of COVID-19 in men and women. No study to date has adequately assessed the effects of ADT on COVID-19 related outcomes. Given the more marked difference in COVID-19 outcomes in men versus women, we hypothesize that men on ADT have improved outcomes compared to men not on ADT. The results of our VA analysis are shown in the next slide and is being tested prospectively in the HITCH study. This slide summarizes our analysis of outcomes of COVID-19 positive veterans on ADT versus all COVID-19 positive veterans not on ADT. We used logistic regression analysis to account for differences in the ADT population versus the non-ADT population. The odds ratio for each outcome is highlighted in yellow with the 95% confidence intervals shown to the right of each odds ratio value. This was a clinically and statistically significant reduction in ICU admissions, need for ventilatory support, intubation, and death. Further analyses comparing ADT patients to prostate cancer patients only and to all cancer patients only is ongoing. The manuscript is under preparation. Two underlying hypotheses may account for the effects of ADT on COVID-19 outcomes. First, the activated androgen receptor induces expression of the two receptors, TMPRSS2 and ACE2, that are necessary for viral entry into pulmonary epithelium. Second, androgens create a state of relative immunosuppression. Specifically, as compared to females, males have reduced innate and adaptive immunity. There have been a number of efforts that have aimed to establish whether the AR is co-expressed with TMPRSS2 and ACE2 in human lung epithelium. Single-cell results have suggested that these three proteins are indeed co-expressed in at least a subset of pulmonary epithelial cells. Preliminary work has been conducted by my colleagues at UCLA under the direction of Dr. Weiwei Yi. Importantly, we have found that the choice of antibody for detecting TMPRSS2 is critical to the results. An antibody produced by Pete Nelson and Lawrence Chu at the University of Washington has consistently yielded the most robust results. This slide shows co-expression of AR, TMPRSS2, and ACE2 in human bronchial epithelium. This slide shows co-expression of AR, TMPRSS2, and ACE2 in the human male nasossinus. This is relevant because we are performing pharmacodynamic studies on nasopharyngeal swabs as a component of the HITCH study to determine if indeed ADT can suppress TMPRSS2 and/or ACE2 expression. The next slides illustrate the effect of castration on the expression of the AR, ACE2, and TMPRSS2 in the murine male nasossinus. In this slide, expression of TMPRSS2 is reduced 4 weeks after castration as compared to intact mice. Similarly, in this slide, ACE2 expression is reduced by castration in the murine male nasossinus. Finally, this slide shows that AR expression is also reduced by castration in the male murine nasossinus. In general, the effects of androgens and castration on AR expression seem to be context dependent. For example, castration seems to induce AR expression in prostate tissue, whereas castration suppresses AR expression in osteoblasts. This slide demonstrates that castration induces thymic hypertrophy in male mice. This is consistent with the suppressive effects of androgens on innate and adaptive immunity observed in humans. Given the information presented so far, we hypothesize that ADT will reduce the severity of COVID-19 illness amongst hospitalized veterans. This is being tested in the HITCH study, a multi-center VA phase 2 randomized placebo-controlled trial of best supportive care plus daguerreolex, an LHRH antagonist, versus best supportive care plus placebo. The rationale for this study has been presented and is summarized here. Specifically, androgens may exacerbate COVID-19 illness by upregulating the expression of TMPRSS2 and ACE2 and/or by inducing a state of relative immunosuppression. So why did we choose dagerelix, an LHR antagonist, as the form of ADT for the HIT study? First, dagerelix induces rapid suppression of serum testosterone levels. 24 hours after injection, serum testosterone is suppressed by 90% or more, and by 3 days, virtually all patients have a castrate level of serum testosterone. In contrast, LHRH agonists such as leuprolide result in a transient increase in serum testosterone, which could in principle exacerbate COVID-19 illness. And they also require 2 to 3 weeks to achieve a castrate serum testosterone level. Potent AR antagonists such as enzalutamide or apalutamide were not selected because they require about 4 weeks to achieve a steady state in humans, a time period that is not ideal for acutely ill hospitalized COVID-19 patients. The objectives of the HIT study are shown here. The primary objective is to determine if the dagerelix improves the clinical outcomes of veterans hospitalized to an acute care ward due to COVID-19, as defined by a reduction in mortality, ongoing need for hospitalization, or requirement for mechanical ventilation. The secondary objectives will determine if dagerelix reduces time to clinical improvement, inpatient mortality, length of hospitalization, duration of intubation, time to achieve a normal temperature, or the maximum severity of COVID-19 illness. The primary endpoint is a composite endpoint of inpatient mortality by day 15, ongoing need for hospitalization beyond day 15, or requirement for mechanical ventilation at day 15 after randomization. Multiple secondary endpoints are shown. Exploratory endpoints will identify whether germline genomic factors such as TMPRSS2 SNPs and baseline serum testosterone levels are predictive of clinical outcome. We'll also assess the pharmacodynamic effects of ADT on TMPRSS2 and ACE2 expression, and we'll also determine the effects of ADT on immune cell numbers and cytokine levels. Shown here is the trial schema. Male veterans who test positive for SARS-CoV-2, the virus that causes COVID-19, by qRT-PCR or nasopharyngeal swab, are admitted to an inpatient acute bed ward for COVID-19 related symptoms will be enrolled. Patients will be randomized 2-to-1 to a single 240 milligram loading dose of dagerelix plus best supportive care versus placebo plus best supportive care. The primary and secondary endpoints have already been discussed. Patients will be stratified according to age, less than 65 versus greater than or equal to 65, presence or absence of hypertension, and influenza severity scale score, 3 versus 4 or 5. The main inclusion criteria shown here. Participants will be male veterans, largely between the ages of 18 and 85 who are admitted for COVID-19 illness. Patients will have an influenza severity score of 3 to 5, which correlates to hospitalized patients. Patients with an influenza severity score of 6, which indicates that a patient has been intubated, are excluded because the pathophysiology of the disease is felt to be related to a hyperinflammatory state in such patients and perhaps no longer dependent on the virus itself. An influenza severity score of 7 indicates a deceased patient. The main exclusion criteria are shown here. We are excluding patients with prolonged QT intervals as well as patients with recent MI, severe heart failure, or liver disease because of the potential risk of dagerelix in these populations. In addition, patients on hormonally active agents are excluded, as are patients with uncorrected grade 3 or higher electrolyte abnormalities. Best supportive care includes, but is not limited to, remdesivir, convalescent plasma, and dexamethasone. Based on published published phase 3 studies, we assume that approximately 60% of control patients will continue to be hospitalized, intubated, or deceased by day 15 after randomization. Assuming an effect size of 42%, we will need 186 evaluable patients, 124 in the dagerelix arm and 62 patients in the placebo arm. Assuming 5% attrition, a total of 198 patients will be required. An interim analysis after half of the patients have reached the primary endpoint will exclude evidence of early futility and efficacy. When this study was conceived, the COVID-19 hotspots included Los Angeles, Seattle, and New York, as indicated by the first group of VAs that were activated. Based on the changing geography of COVID-19, multiple additional VA medical centers have been recently added. The study is open and actively enrolling at these sites. I would like to acknowledge support from the VA, the PCF, and my academic colleagues. At UCLA, Andrew Goldstein has directed preclinical mouse studies, and Weiwei Ye has conducted the immunohistochemistry studies. Pete Nelson and Larry Chu at the University of Washington provided the TMPRSS2 antibody. Rebecca Levine at the PCF has been instrumental in the initiation of this study, given her key role in the VA PopCap program. The design and execution of the HIT study was made possible by my VA colleagues, including Nick Nichols, Rachel Ramoni, Terry Gleason, and others. The VA data analysis was conducted and led by Kyung-Min Lee, Jennifer Lee, and Julie Lynch. Thank you for your attention.
Okay, so it seems like there's been a lot of interest in these talks. A lot of questions have been rolling in. So let's get started with the first one. Charlotte Bevan from Imperial College asked the question, does co-treatment with an AR antagonist and BRD inhibitor have additive or synergistic effects compared to single treatment? I think that's a question for Dr. Chennai.
Yeah, that's an interesting question. Certainly in prostate cancer, in terms of prostate cancer preclinical models, we have shown we and others have shown a nice synergy between the use of AR antagonists and BET inhibitors in terms of regulation of the key transcripts in the prostate lineage. We actually have not done that experiment in terms of our SARS-CoV-2 infections in vitro. However, I think one could potentially propose that, and I think it could be quite intriguing to essentially see potentially a similar sort of synergistic effect by combining the two agents.
Lourdes Guerreros from Caribbean Healthcare System in San Juan asked a question about racial disparities, given the fact that TMPRSS2 ERG gene fusions are less common in Black men. How does that align with the current, what we know about COVID-19 and prostate cancer disparities for any of these studies that were racial differences evaluated?
Yes, it's a great question. We have not looked at racial differences in our limited cohort of lung tissues that we have, but it's certainly an interesting hypothesis to essentially assess whether there are TMPRSS2 expression differences between, say, African Americans and whites and so forth. But we have not done that aspect.
So the next question is from Mohammed Asim at the University of Surrey, who asked, why would levels of AR go up in older men? And is there any link with smoking or lung regeneration?
Yeah, that's a great question. In terms of what the mechanisms are of increase in older men, we have seen an association with smoking, certainly, of AR levels, and some of these older individuals have also been prior smokers as well. And we have seen a strong association with smoking as well in terms of increasing AR levels.
So you've been getting all the questions. I'm going to go to Dr. Vinetz. Evan Yu from University of Washington asked the question. He says, thanks for the great talk. You mentioned your primary endpoint is change in viral load from swabs. Have serial viral load specimens been correlated with outcomes with COVID-19? And for that matter, is there an association with outcomes for other viral infections?
Well, let me answer the second question first, which we know that for HIV, you get rid of the virus, you have much better outcomes. We know that theoretically, if you stop viral replication very early in influenza, that has at least with drugs, as a one-day improvement of symptoms, resolution of symptoms. We don't really have a lot of other rapidly acting antiviral, for acute viral infections. If there was no virus, we'd have the best outcome. If we get rid of virus faster, presumably we would have better outcome. Theoretically, and there's no data. So now going to SARS-CoV-2 infection, we don't know. That's why we do a trial. But I would just comment that lower virus faster would mean less chances for endothelial activation, dissemination of virus to heart, brain, or kidney, etc. It's not a viremic disease, so it's really somehow it gets out of the respiratory tract and disseminates to cause very bad complications. The complications really are host response. And so, again, theoretically, and we're going to find this out, the reason for looking at viral load reduces the number of patients that we have to see a biological effect of the drug. And since the protocol is harmonized with a clinical outcome study later on, 114 patients randomized into two groups, if we see a signal of efficacy, and we have a very minor signal, between day 0 and day 4, a half log reduction in viral load in serial samples, if we get that primary outcome to show at least a modicum of an antiviral effect, the next 600 patients or so, or to complete 600 patients, will give us a clinical outcome, because the advancing of symptoms from the early onset to complications, hospitalization, hypoxia, et cetera, only happens in a minority of patients. And so this is just like phase 2A. And so if we see a biological effect, that supports the ethical extension to 600 patients or so. And finally, we will be, if there's an amazing effect, like overnight people feel magically better, we will be able to find a strong effect, because we're obviously looking at oxygen saturations, other vital signs, and clinical. We have a very detailed COVID-19 PRO, patient-reported observations. So we'll find out a strong effect early. Long-term outcomes, we don't know. That's why we do clinical trials.
So Lorelei Mucci from Harvard School of Public Health has a question for Dr. Reddick. She says, intriguing analysis of the VA population, the COVID outcome analysis. Are women included in the all COVID positive, and are the estimates age adjusted?
No, so women were excluded. There are, of course, a very small percentage of the VA population is represented by women. So no, we didn't, and they are age-adjusted statistics. Also, just add one other point related to a question earlier about health disparity. So the VA is a good place to study health disparity. In some of our VA systems, such as our hospital in Los Angeles, upwards of 40% of our patients are African American, and we will be trying to tease out some of the genomic factors that may predict for outcome. So we are doing germline sequencing on these patients in exploratory studies to see if we can identify any genomic factors that may predict for improved or worse outcomes, as well as response to therapy. So we'll be studying that and looking at factors such as TMPRSS2 SNPs and other relevant factors.
Dan Frigo from MD Anderson asked a question: while the shifts in sex hormones have been hypothesized, mainly androgens have been functionally studied. Are there any data for or against the protective role for estrogens? I think this could be Dr. Reddick or Dr. Chennai.
I can tell you what we've done. We had done a similar analysis of publicly available RNA-seq data sets, and we do see that estrogens seem to suppress TMPRSS2 expression. So the opposite effect is observed with the female sex hormones as compared to androgens. Interestingly, one of the observations that we had was that when in reviewing these databases, that estrogens actually result in a very early but transient increase in TMPRSS RNA expression, followed by a drop. We actually had considered using estrogen as one of the arms in our study, but for that reason, as well as the potential for estrogens to induce thromboembolic events, especially in patients who have COVID, who are at increased risk for clots, as we know. We do not use that therapy as one of the arms, and we also did not do a study in women. We just don't have that patient population, and we also excluded women for our current study, the castration-based study, because that would reduce estrogens in women, and thereby may actually increase the severity of COVID-19 in female population.
Stephen Plymate from University of Washington asked a question: what are the effects of obesity, especially since fatty acid synthase and other lipid synthesizers are AR targets? I think anybody can take this if you're aware of any data.
I'm not aware of any. Good question.
Okay, yeah, important question. Josh Russo from Beth Israel asked a question: are there any other proteases that can take over TMPRSS2 activity and process the spike protein? Might these also be affected by ADT? Maybe Dr. Benetz or one of the other speakers?
So I think
I can give it a shot.
Go ahead.
Okay.
I mean, there's a bunch of proteases. People have looked at a bunch of them. TMPRSS2, at least in the Hoffman studies, is both necessary and sufficient. But the problem with serine protease inhibitors is all these inhibitors have different affinities for the enzyme itself, to quite variable degrees. And it's unclear whether another one in vivo, because there's no data on whether another surface serine protease inhibitor in vivo can take over for TMPRSS2. We just don't know that. Presumably, it would have the same inhibit. We don't know, but it would presumably have a similar inhibition enzymatic profile. So that's my knowledge, but I'm a newbie in this, so I will defer to the experts.
Yeah, and I would say that in terms of S protein cleavage, I believe that TMPRSS2 has been the serine protease that's been implicated in terms of the activation of the S protein, but certainly other proteases have been implicated in SARS-CoV-2 infection, especially in terms of the endosomal sort of pathway activation, including enzymes such as furin and certain cathepsins and so forth have also been implicated. But I'm not aware of another serine protease or other protease otherwise in terms of the S protein activation.
So Andrew Armstrong from Duke asked a question: how do you incorporate evolving standards of care for severe COVID in these clinical trials?
I can take a crack at that one. So we allow for any of the standard of care therapies to be included. In our study, for example, we allow for a remdesivir, a dexamethasone, convalescent plasma used in the context of the emergency use authorization, and we are constantly searching the literature and are going to be flexible in allowing other therapies on board. So we're trying to be as liberal as possible in that regard to mimic what would be done in clinical practice outside the context of a clinical trial, and also to allow our veterans the access to the best therapies.
Jonathan Simons has a question. Jonathan Simons from Prostate Cancer Foundation asked a question about both clinical trials. Where are they with regard to accrual as of today?
So we are open and accruing. We've accrued at GLA, and there are multiple other sites that have recently come on board. I think I mentioned in my talk when we start, the idea or concept for this came up back in March when New York, Seattle, and LA were the hotspots. And those were the sites where we had the study open. Time we actually started to enroll patients, those were no longer hotspots. So we went to the second wave of sites, and which were the hotspots like Phoenix and Houston and Dallas and sites in Florida. And now that they're open, those are no longer hotspots. I can say that we're seeing a resurgence, of course, in COVID across the U.S. in most states. I can't say that I hope we have more COVID, but I think that we will accelerate enrollment. We have just only about 10 patients that have been enrolled at this time.
So that's all we have time for. So I want to thank all the speakers in the audience, and please return back to the lobby to go to the next session. Thank you.
Thank you.
Thanks very much.